We need to act it today. We cannot wait for tomorrow.
Nobody can do this alone.
Early action saves lives.
Empowering our women is also a way forward.
Zero dose children should be a priority.
If we work together across boundaries, we know we could eliminate this cancer.
Getting 0 is very possible.
Hello, and welcome to Getting to Zero, where we talk to leading global public health experts about how to reduce preventable illnesses and deaths via immunizations and other prevention strategies. To stay connected to these conversations, be sure to like and subscribe below. I am your host, Nicole Basta, Canada Research Chair in Infectious Disease Prevention, Associate Professor of Epidemiology at McGill University, and the 2024 Sabin Vaccine Institute Rising Star awardee. I am delighted to be joined today by Professor Sir Brian Greenwood, Emeritus Professor at the London School of Hygiene and Tropical Medicine. Sir Brian's many decades of pioneering work on malaria have been truly inspirational, and without a doubt, instrumental in the development, approval, and introduction of the first malaria vaccines. Malaria vaccines have now been introduced in 18 countries via routine childhood immunization programs. This is a remarkable achievement that has ushered in a new era in malaria prevention. Welcome, Sir Brian, and thank you so much for joining me today.
Thank you. Happy to join you.
Now, Sir Brian, you began working on malaria more than 50 years ago, but it was just in these last few years that the first safe and effective malaria vaccines were approved by the WHO. Can you tell our viewers a little bit about the history of malaria vaccine development? Why was it so difficult to develop these vaccines initially?
Yes, I'm happy to do that. So it's been it's been going on for about 100 years, and it first was shown that it was possible to have a malaria vaccine in the early very 1900s, but that was in birds. Then it got to sort of experiments in mammals, but really the sort of human malaria vaccine started in the 1960s with the discovery by Professor Lirzenzweig in New York that if you irradiated the sporozoite, that's the part of the parasite that's injected when the mosquito bites somebody before it gets into the blood and then into the liver. And if you irradiated it and then sort of partially decreased its ability to cause infections, that could be used as a vaccine. And that was done first in animals, and then it was shown that you could do that in humans. That Dr. Clyde in the 1970s. But to vaccinate a person, you had to get them bitten by lots and lots of mosquitoes, and that clearly wasn't the practical thing to do in the field. So the real breakthrough came for the vaccines that we now have and which are now being used came from Dr. Joe Cohen at GSK, and he found a way of using a protein on the outside of the sporozoite, the one that gets into the blood from the mosquito, and turning that into a pup with combining it with hepatitis B antigen and then making it into a virus-like particle, which was much more immunogenic. And that was a practical way you could inject that, like we do with the other vaccines. And that was shown first, I think, in about 1997 in volunteers in America that this vaccine worked. And then the first trial in an area where malaria was endemic, which was in the Gambia, which was in 1998, and I was involved in that project. So I think I actually designed the protocol for it. So I've had about 25 years, or more than 25 years of involvement in this vaccine. And then it is taken from that first study in the Gambia, which showed that it worked. It has taken that very long time to get it approved by WHO. And I think we've got lessons to learn from that. I mean, we know from COVID, when there's a real need, you can develop your vaccine faster than that. And it's a bit unfortunate that it's taken all that long time to happen. And now we have two vaccines, the RTSS vaccine, R21 vaccine developed in Oxford by Adrian Hill and his group, which has the same principle, but is made in a different way.
And clearly these vaccines have gone through extensive testing through clinical trials, and there's a great deal of evidence for their safety and efficacy. Can you talk a little bit about how community partnerships have contributed to the development and testing of these vaccines?
Well, that's clearly been absolutely essential that people know what's going on. And it is interesting, as we know that with some vaccine, like the COVID vaccine, there's been we call vaccine hesitancy, a lot of reaction against that. And to me, it's not surprising, having lived in Africa for a long time where malaria is such a big problem, that hasn't been a problem with the malaria vaccine, because the communities recognize that. They've seen next door neighbor's child die, perhaps even one of their own children die, seen the hospital full of children in the malaria transmission with severe malaria, lots of anemia, and so on and things. So there is an understanding that this is a horrible disease, and I think that's helped. And there have been an odd hiccup now again, but on the whole, the coverage has been very high and people have accepted the vaccine. But obviously, in testing it, you have to take blood samples, people have to turn up to the clinic regularly, and I mean, this is asking quite a lot of people to be involved in one of these trials. But the coverage in most of the malaria vaccine trials has been very, very high because people realize how important it is.
Yeah, you make a very good point that malaria continues to take a significant toll, and people are really aware of the pain and suffering caused by malaria. Malaria is still responsible for over 260 million cases and nearly 600,000 deaths, mostly among children each year. And so while we've come a long way in overcoming a lot of challenges, there's still a lot of work to do. In your view, what are some of the greatest and most urgent challenges facing malaria elimination today?
Well, I think we've got sort of two sets of challenges. One is the ones related to the parasite and the mosquito that transmit it, and it's a pretty clever parasite. And we have three parts of the life cycle: in the mosquito, in the liver, and then in the blood. And that's so much more complicated than trying to develop a vaccine against, say, like the COVID vaccine, when the virus just has a few antigens, you get the right one, you've got a vaccine. So that there are challenges there. That also it has different methods of doing the same thing. Like when the parasite is trying to get into the red cell to infect it and cause anemia, there are several different ways it can do that. And if you produce a vaccine against just one of those, then it will use another route to do that. And it is striking that if you live in a highly endemic area for malaria and you get to be 91, you've probably had hundreds of episodes of malaria, been exposed to the parasite that number of times. And yet, even those elderly people in endemic areas, they're not going to die of malaria. Well, it's very unlikely that will happen, but they still are exposed to infection. So it is really difficult to develop an effective immune response that will stop the parasite completely in its tracks.
What about some of the challenges to the implementation of vaccination programs and other control strategies that are used for malaria?
I mean, we can do what we can to get a good vaccine, but and it will cost money to make it, it costs money to deliver it, even when it's produced at large scale. And so then you've got the problems of, can poor countries, which are really struggling, afford to do that? If they can't, then what about the AIDS budget from wealthier countries helping them out, giving money to the Gavi, which helps a lot of the countries with that vaccine? And this is not looking a very good time for that, I think, because we're all aware of what's been happening in the last few weeks. So that is a real worry. So you've got to have the financial support. And some of the countries where malaria is endemic are doing better now at funding it themselves. But the very poor ones, I think it's really hard to do that. And then you've got to have a health system that's really able to deliver your vaccine effectively. And I think when people talk about malaria elimination, getting to zero, it's really difficult to see how you would do that in somewhere where there's no health service that's functioning, people are fighting, the civil disturbance and so on and things. And so I think, as well as having a good vaccine, we need the financial support, either internally from the country that's doing well with its economy, or the poorest countries from outside, and then a health system that can deliver that and give a very high coverage with the vaccine. And probably we need, for measles vaccine, you need sort of 90% coverage for that, people getting the full course of the vaccine. I think that's likely to be the case with the malaria vaccine as well.
And so overcoming these challenges and getting to zero for malaria, as you said, will no doubt require many dedicated efforts from many partners and the global political will to make this happen. It will also require a dedicated public health professional workforce. Throughout your career, you've invested significant time and effort in training the next generation of disease prevention specialists. And I know this firsthand since I benefited from your mentorship when I was a student myself. How critical do you think it is for this next generation of public health professionals to make a commitment to expanding efforts to reduce malaria, to move this agenda forward?
We had a very important meeting in 1997 with the MIM meeting, the Malaria Multilateral Initiative on Malaria. And that's probably the most important meeting I been to in my career, because at that meeting it was when malaria first came up on the sort of agenda that we needed to do something about it. And this was in Dakar, Senegal, and the director of NIH came and stayed with us and took part, and then he went to Mali and so on. And that was a real shock to some people, that it was seen that one of the most important people in the scientific world was taking malaria seriously. And at that meeting, the really exciting thing was that there was a commitment from everybody from different groups. I was part of the organising committee. I persuaded them to have an economist at the meeting, which was unusual at that time. And so we had social scientists, molecular biologists, vector people, and parasitologists, clinicians. And there was an agreement. People weren't saying, well, they were asked, well, what was the most important thing? And nobody really pushed their own individual things. So, well, that's the magic bullet. We should put all the money in vaccines and so on and things. And I think that was a really important lesson. And I think that is still the same now. If we're going to really get effective control, we need all those people in many disciplines, like you were talking about, getting uptake, hesitance, vaccine hesitancy. Social scientists, anthropologists, we need people working in the lab, we need people who can actually deliver and do proper clinical trials and so on. So, and that is what to me has been one of the attractive things of working in this sort of area. You need people with a whole lot of different disciplines. And so we need, and I don't think we should just give up and say, put all our money in vaccines. Something we need that for now. And so we need trained people in all of those areas who can work together. But having a really strong multidisciplinary force of people who can work on malaria control, I think that would be essential to the success of really getting to elimination.
Sounds like global coordination of individuals with many different areas of expertise who are committed to malaria prevention and control are going to be really important in the future.
Yeah.
How important would you say improving accessibility and access to not only malaria vaccines, but other tools for malaria prevention are going to be in the next few years?
It is possible that we do get a malaria vaccine that 95% protective and gives you protection for 10 years. Or the other area that really could be game-changing is gene-modified mosquitoes. And so you get rid of by the gene being transmitted generation, you get rid of the vector mosquitoes. And so we need to be aware of that. But I don't think we give up on all the other things that we need to do and keep up, the research. And then there's also really now we have a vaccine. I think we need to happen with new studies going on. We need to know how to use that and deploy it most effectively in different situations, and how you do that in areas of Mali where the malaria is only present for a few months in the year may be different from what you do somewhere in DRC, whereas malaria transmission is raining all the time and malaria goes on all the year. And I think there's a lot of research needed on that now that we have these tools, how best we use them and how best we can use them in combinations, because it is quite exciting. We have 4 or 5 things on the menu now, whilst 20 years ago we didn't really have, perhaps one, the insecticide-treated bed nets, and how we won't be able to afford to give all the interventions everywhere to do that, and that may not be a sensible thing to do. So I think a lot of the sort of research needed in the coming years is really learning how to use these combinations and things most effectively in different areas.
That opens up a lot of research possibilities in terms of the public health strategies that can be tailored to different contexts and different epidemiological settings, which I think is a really exciting area for malaria research going forward.
No, I mean, like the study we just started now in Mali, when this part is both in Mali and Guinea, the part in Guinea is looking to see whether you give your booster dose, whether you wait until just before the rainy season and then give it then, or do you have an age schedule when you say everybody gets their booster dose when they're 12 months old, which would be easier to deliver that. Now, it sounds very sort of simple and a bit basic and so on things, but it's a really important question to help which of those practical solutions would actually give you the best money, best value for money for using the vaccine in the number of cases you prevent.
Yeah, these types of strategies for optimizing vaccine delivery and ensuring that we get the most benefit from the vaccines that we have, especially in combination with other prevention and control methods, are really important aspects of public health prevention and control. So I want to end our conversation on a positive note as we look ahead to the future. As you probably know, a recent WHO analysis found that malaria control efforts have prevented more than 2 billion cases and saved more than 12 million lives since 2000. What would you say are two of the most important priorities that we should be focusing on right now to be able to reduce malaria cases further and to save even more lives in the years ahead?
So if I've got two choices, can I have three?
Yes, you may.
One is to keep up the research on all the different aspects that we've talked about, not just to focus on one. The second really is to make sure that there is the funding, encouraging countries, which some that are doing, malaria endemic countries doing quite well now financially. They should be putting more money, their own money, into that. They are doing that. That's definitely the case. But really, in the poorest countries, which have very limited resources and so on and things, there will need to be support from outside, from the wealthier international. It's very sad to see. I mean, like my own country's just cut its aid budget. When the UK's made major contributions to malaria control in the past couple of decades and put quite a lot of money into doing that. So we've got to somehow try and keep up that outside support for the countries that genuinely need it, and we'll use it properly. And then finally, as we discussed, my number three is you have to have a health system that's working, that can deliver these things. You know, if the money to support it, but if there's corruption, it doesn't work, and so on, then that's not going to get rid of malaria either.
So really advocating for a multi-pronged approach where there's significant investment at different levels so we can tackle a number of different challenges that are in the years ahead. Excellent. Well, thank you so much, Sir Greenwood, for joining us today and for sharing your insight. It's been such a pleasure speaking with you.
Okay, fine. I've enjoyed it.
And thank you to all of you who have tuned in from near and far for this episode of Getting to Zero. See you next time.